Okay, so just real quick, I want to do a special topic lecture on hemodialysis access, specifically grafts and fistula. So remember that you got a situation where a patient needs dialysis. You basically have four options. You have three vascular options, and then you've got peritoneal dialysis. So let's just talk about the vascular option. So the first vascular option would be like in acute setting, you can put in a temporary catheter, right? So you probably put those in before. So we're not going to talk about that. We're going to talk about those are temporary. We're going to talk about the more permanent and the really semi-permanent options, which are hemodialysis grafts and hemodialysis AV fistulas. So people who don't know what they're talking about will use these terms interchangeably. They'll just say, they'll call a graft, everything's a graft or everything's a fistula. So there are actually two different subtypes here. So generally speaking, we've got fistulas, which are exactly what you think they would be. They're a subcutaneous anastomosis between an artery and an adjacent native vein, for example, radial artery and cephalic vein. And then you've got grafts, which is a subcutaneous anastomosis between an artery and a native vein, but except this time you use a piece of synthetic tube graft in between the two. Now, all things being equal, the preferred access is the fistula. Fistula is better than the graft if you had to pick one. Let's say you unfortunately would need dialysis, that you would prefer to have a fistula. So why doesn't everybody get a fistula? Well, there are pros and cons, so let's talk about it. So here are some of the pros of the fistula. These are all pros on this slide. All right, so the fistulas last longer, they're more durable, they're less prone to the development of intimal hyperplasia and then as a resulting downstream issues. The pros to the graft are they are more rapidly available to use, they mature quicker, and they're easier to declot. If the clot is confined to the synthetic graft portion anyway. So cons: the fistulas take longer to mature. That was the big pro of the graft. And again, overall grafts don't last as long, and they promote this hyperplasia of the venous intima. So, and because it's an artificial, it's a foreign body basically. It can be a nidus for infection. All right, so pretty much no matter which type you choose and which route you decide that you're going to take, they both end up in the same spot, which is here. So the natural history of a vascular access graft or fistula is progressive development of neointimal hyperplasia stenosis, which results in reduced blood flow, which compromises the performance of the vascular access, and if you leave it untreated, will eventually lead to thrombosis and failure. So they all fail. They all fail. I can remember, I don't do these things anymore, but I used to, and you go and meet with these patients, and they would be like, did you get it fixed yet? I'm like, no, there's no fixing it. There's no fixing it. You know what I mean? There's like temporary, I declotted it. Yes, it's declotted. I'll see you back when it's clotted again. Yes, I angioplastied it. I'll see you back when you have a new area of stenosis. So it's just, you're plugging little holes in the dam, and eventually they go down. So they all fail. All right, so usually, when do they come to see you as an interventionalist? When do they come and see you? They come to see you for slow flows. So what exactly does that mean? What is slow flows? So here's some slow flow. Are they talking about that slow flow? Usually talking about that slow flow, specifically into this particular region right here. So, nephrologists get paid per dialysis session. So if your session is 4 hours because you have slow flows, they make the same amount of money as they would make if your flow was fast, then they could dialyze you in an hour and a half. So then they could, run 2 or 3 patients in the time that it would take to run you with your slow flow. So they're like, fix it, make it run faster, because that's big money for them. So the nephrologists are always putting pressure on the interventionalist or whoever. Sometimes nephrologists can be trained actually to declot and do these things themselves. Because remember, radiologists' specialty is teaching other people how to do their jobs. So, but regardless, they want the flows fast because it's all about the money, Lebowski. So, when is slow too slow? So this is sort of testable numbers. Now it differs. Usually, what you're going to hear is 600. Some places you'll read 700 to 800 for grafts, and 500 for fistula. But I would remember 600 and 500. Now, having said that, like I said, some text will tell you that a fistula can maintain patency with a rate as low as 80 cc's a minute. So it's sort of partially bullshit, but for the purpose of multiple choice, because remember who's writing these questions, right? Are people who make a living doing this kind of stuff, so they're always going to err on the side that it works. So for the purpose of the exam, less than 600. If you've got less than 600 and you decide, then okay, we're gonna try to treat something. There's a pretty good chance that you've got at least one significant area of stenosis. All right, so how do you work these things up? So the classic teaching is the first step when the patient comes to you with a problem or low flows or whatever it is. The first thing that you're supposed to do is examine the patient. I know, it's terrible. Horrible, ridiculous thing to ask a radiologist to do, to actually touch a patient, and even worse than that, talk to them. If you've ever encountered a dialysis patient, then you know how bad that can be. So obviously in the real world, what you would do is get a mid-level provider to take care of this for you, but for the purpose of the exam, we shall discuss what you're supposed to do. So they say, you'll read, that if an abnormality is found on physical exam, about 90% of the time you're going to have an angiographic correlate that's significant. So that's why they tell you to do it. And it helps you sort of figure out how you can plan your access and those kinds of things. So you're supposed to look, listen, and feel, just sort of like the CPR thing. So if you've got marked arm swelling, this usually indicates central venous stenosis. Dilated veins and collaterals are usually apparent on the patient's upper arm, chest. It may have swelling of the breast in a female. All of this is sort of making you think that central venous access. All right. A discolored hand or pallor, you'll hear that word as a buzzword. If you don't remember, pallor means pale. They may also tell you that there's pain. This is sort of a buzzword for dialysis-associated Steele syndrome, which usually people just call Steele syndrome, and we'll talk about that more a little bit later. Listening. All right, so should there be a bruit? Yes, should be a bruit. The bruit should be low-pitched in the outflow vein, and that's an expected finding. However, if it's high-pitched or if it's you're auscultating the graft, particular in the region of the venous anastomosis, you may hear this high-pitched, harsh, discontinuous bruit because you're getting a velocity increase at that level of stenosis. So wherever you're hearing that high-pitched noise is supposedly, if you believe in anything physical exam related, where the area of stenosis is at. And then feel, all right, so flow through the access can be evaluated by assessing a thrill, which is like, a vibration heard at various points along the access. So when there's a stenosis present, it's supposed to be like a water hammer pulse felt below the area of stenosis, and above the stenosis, the pulse sort of just can be very diminished or almost absent. So Again, that's the make you think stenosis. So, all right, so now that we've done the physical exam, we're going to go and we're going to do a fistulogram. All right, so but before we start, we should discuss contraindications. So there's really only one, which is infection. So that's an absolute contraindication for percutaneous intervention, is an infected vascular access. Manipulation of infected graft or fistula can cause dissemination, vascular dissemination of microorganisms, and cause full-on sepsis, osteomyelitis, endocarditis, etc., etc. You're not supposed to mess with infected grafts. So if the question is absolute contraindication for fistulogram, the answer is infection. What about IV contrast? That is a contraindication, but usually there's an alternative, which is to do CO2. All right, so what about relative contraindications? You will read some places that new grafts or fistulas less than 30 days. If you're in there mucking around, dilating a new anastomosis, you can disrupt the integrity. But this is more, like I said, of a relative one. Now, if you've got a significant anastomotic stenosis within 30 days of creation of this vascular access, it's way more likely you've got a technical or anatomic problem, and that's going to require surgery for a revision for optimal long-term patency anyway. So the practical pearl or real-life pearl is if somebody comes to you as a referral and they've got an issue and the graft or the fistula is less than 30 days old, they need to go back to surgery probably because you're not going to be able to fix it, whatever's wrong with it. And long segment venous stenosis or occlusions are also considered a relative contraindication for percutaneous management. Short, and what do I mean by short, like less than 3 centimeters, they compared to, basically, short ones are going to have better treatment. Longer ones are you're going to have suboptimal immediate success and reduced long-term patency. So that's sort of, so if you're confronted with a lung lesion or multiple segments of venous stenosis, you're supposed to sort of make a decision on whether or not they should be going back to the surgeon. All right, so here, let's do some lingo. So I'll wheel you in the direction of flow, right? So we're going from the artery to the vein. So remember, this is all under the skin, right? So if you're unsure which limb of the graft is venous and which one is arterial, a trick you can do is you can put some manual compression. It's sort of at the apex of the graft. And what that's supposed to do is result in absence of pulsatility along the venous limb because you're blocking the flow, whereas the arterial limb will have continuous, that's the part that's still pumping. So typically, the venous limb is punctured in an antegrade fashion. What do I mean by that? I mean pointing towards the venous outflow, since that's usually where the problem is. Retrograde puncture might be needed if there is arterial inflow or intergraft stenosis. So here's a graft. So in grafts, typically the stenosis they'll tend to develop in the venous outflow within a few centimeters of the graft vein anastomosis. It's usually due to neointimal hyperplasia. And when you've got this venous stenosis, you're going to have an increase in the amount of recirculation in the graft, increased pressure throughout the graft, and an increased likelihood of thrombosis. Fistulas, on the other hand, the stenosis tends to occur just distal to the arterial anastomosis, or near the puncture site of the vein. Stenosis in the fistulas have variable effects, sort of depending on the anatomy. Stenosis just distal to the arterial anastomosis will cause the fistula to appear flat because blood flow is not going through the outflow vein. A stenosis further into the outflow vein may increase the pressure in the more proximal vein, and or if there is a collateral vein, these veins may decompress the fistula, and you may end up you can develop larger collateral veins. If the side branches are occluded, venous stenosis can give rise to a situation very similar to a graft, where you have increased recirculation pressure, and then as a result, an increased risk of thrombosis. Okay, so got two pictures here. Both of them look like they're stenosis, and most of the time you'd sort of be right, but you could be asked a question where it was something like, how could you distinguish between a fixed stenosis and a venous spasm? In general, venous spasms typically appear long, they're smoothly tapered, and then and they're often near the point of access. So that would be like the morphology thing, long and smooth. The other thing you could do would be you could administer a vasodilator like nitroglycerin directly into the venous segment, and if it is fixed stenosis, it won't change, but if it's vascular spasm, it will resolve, something like that. So how do you treat the lesions? You're going to do angioplasty, and your goal, or what should happen, is you should be able to improve flow through the graft by at least 20%. When might you put a stent in? Two main reasons. One would be you're getting really bad elastic recoil, or two, you've already had recurrent stenosis within 3 months of angioplasty previously. So, and this is going to be different depending on what you read and who you ask, because it's sort of institutional, but in general, something along these lines is how it works. So give them heparin. Again, some people say you don't give them heparin. Some people say yes, you do give them heparin. Where I trained, we gave them heparin. Give them heparin, like 3,000 to 5,000 units of heparin. Cross the lesion with a guide wire. Exchange your catheter for a 5 or 6 French sheath over an 0.35 inch guide wire. Dilate the narrow spot with a 6 to 8 millimeter balloon, usually with repeat multiple prolonged inflations. Remember, you never take the balloon off the wire. When you're doing these diagnostic runs, you might need to put it rapidly back on if you caused a tear. So how do you size your balloon? So general rule is that you want the balloon to be 20 to 30% larger than the diameter of a normal vein adjacent to the stenosis. So typically 7 or 8 millimeter diameter balloons are used to treat vascular related stenosis. But that's how you would make a decision. So what do you consider success? Success would typically be less than 30% residual stenosis, or even better, resolved symptoms in the arm, like arm swelling or whatever, is gone away. So complications. The most common complication that occurs during percutaneous treatment of a failing hemodialysis graft or fistula is angioplasty-induced venous rupture. And you see this about 2 to 3% of the time during procedures. In many cases, the perivascular hemorrhage can be effectively controlled by manual compression or by balloon tamponade. That's why you got the balloon on the wire still, because you see this picture and then you put your balloon back on and you blow it back up and you get some balloon tamponade. Now occasionally the injury is more substantial and you have to deploy a stent to control the bleeding and repair the injury. Patients, especially patients with AV fistulas, are prone to develop stenosis in the upper cephalic vein, the so-called cephalic arch, and these lesions are notorious for angioplasty-induced rupture. So typically when you see it, that's where you see it happen. Okay. All right, so I just want to quickly hit on 3 vocabulary words here that I think are testable potentially. So primary patency, primary assisted patency, and secondary patency. So primary patency is your intervention-free access survival. So most places will define this as the interval from the time of access placement to any intervention designated to maintain or reestablish patency to access thrombosis, or the time of measurement patency. Assisted primary patency which is, you can think of this as thrombosis-free access survival, is defined as the interval from the time of access placement to access thrombosis, or time of measurement of patency, including intervening manipulations, either surgical or endovascular, designed to maintain the functionality of the patency access. So this is thrombosis-free survival. And then lastly, secondary patency is access survival until abandonment. So this is defined as the interval from the time of access placement to access abandonment, or time of intervening manipulation, be it surgical or interventional, endovascular, designed to reestablish the functionality of the thrombosed grafts. In other words, the graft is down and completely down and out, thrombosed, and they're trying to make it functional again. And assisted primary, or primary assisted, you're treating it, trying to maintain the functionality, okay? And then in primary patency, it's the point of which it becomes no longer patent. All right, so got a patient here, and the history provided is cold, painful fingers during dialysis that is relieved by manual compression of the fistula. So that is Steele syndrome, history for Steele syndrome. So too much blood going to the fistula leaves the hand ischemic. The issue is usually a stenosis in the native artery distal to the fistula, or sort of like already got a like less flow going through there, and then once you start like taking some of the flow out more proximal to that, then it can't autoregulate or respond to it, and you can get an ischemic hand. So how do you treat that? For the purpose of multiple choice, the answer is surgery. Okay. Now again, you'll read lots of different stuff. There's lots of opinions on treating this. Where I train, the answer is surgery. Most things you will read will tell you surgery, and what kind of surgery depends on how bad the situation is. So if you've got an acutely threatened limb, they'll tell you just to straight sacrifice the fistula. If it's got low or normal access flow, usually what they'll say is to do the drill procedure, which is a distal revascularization of the extremity. And if it's a high access flow, then they'll band it to reduce the flow. If you're, in other words, if the access is stealing all the blood because it's a high flow thing, then the problem is in the access. If it's really not stealing that much flow, then the problem is further down in the arm, and you have to do a revascularization there. And if they're going to lose their arm, then you need to not do that. Put a temporary line in, kill the fistula, let their hand, not die, and then put a fistula or graft in the other arm or somewhere else. All right, so not done with this yet. Let's talk more about the Steele syndrome. So this is typically the Doppler that you'll see, and you're Dopplering in the radial artery distal to the anastomosis, so along this yellow box to yellow box here. So what you're seeing is the flow is antegrade during systole, and it's retrograde during diastole. That's sort of classic. Now, if you put manual compression, gentle compression at the fistula, that's supposed to improve. Remember I said that would improve the flow. So manual compression here, and then you're going to see a change in the waveform where now your diastolic flow is in the forward direction. Okay, so what if it's clotted? Two basic ideas here. One, just as in general speaking, if it's soft and it's small, you should be able to macerate it with a balloon. Most people will say that it's worth trying to recannulize a thrombosed fistula. even if it's immature, and there's a good chance of trying to restore flow and allowing it to develop into a mature fistula. So small clots, people will go after those and try to chew those up with a balloon, especially if they're soft. You've got a pretty good chance of being able to handle that. If it's hard on palpation and it's a long segment, the balloon maceration alone, it's probably not going to get the job done. You might have to use other tactics to try to get it out of there, which I'm not going to get into. But and remember, a contraindication, percutaneous intervention, contraindicated in acute infections of the vein or perivenous space, so like an overlying infection also contraindicated. What about this guy? What about aneurysms? So again, you'll read different things. Where I train, the answer was surgery. For the most part, if it's a stable aneurysm, you can observe them. People in dialysis have aneurysms all the time. So if it's stable in size, you're just following with baseline measurements, simple surveillance, both clinically and with ultrasound. You'll worry about these things rupturing. The risk of rupture is actually quite low usually because we're talking about thick-walled. These things are usually thick-walled, but you would start to worry about it being rupturing when you've got a rapid increase in size, pain, the overlying skin is starting to look abnormal, and in those situations, then they're gonna have to go to surgery. A growth of 10% per year is what you'll read a lot of times as an increase for rupture. Skin thinning, skin atrophy are also sometimes indications, at least for a referral to surgery. All right, there you go. That's it for this topic.